Case study from Ms. Joanne. Chief of complaint, headaches that have been occurring more frequently over past 2 weeks. History of present illness. Ms. Joanne is a 35-year-old female who presents with complaint of headaches that have been occurring 3 to 5 times per week over the past 2 weeks. Reports taking ibuprofen for headache without any relief of symptoms. Rarely she has had headache after a stressful day. Denies any premenstrual headache. Reports left-sided throbbing headache in the temporal area with a pain level of 7 on a scale from 0 to 10. A pain lasts for several hours and goes away if she able to fall asleep and get some rest. Reports occasional nausea with headaches, but rarely vomits. Reports sensitivity to light and sensitivity to noise with the headache. Reports spots in front of her eyes right before the headache begins. Denies any other problem with vision. Denies any nosebleeds with a headache. Denies any upper respiratory tract symptoms or sinus problems. Denies any trauma to head or neck stiffness, and denies any fever, chills, numbness, or weakness. Let's go over her subjective data. Her medical history, she has nothing, she's pretty healthy. Surgical history, she had 3 vaginal deliveries, uncomplicated. Her allergy only is to penicillin, and her medication, she only takes ibuprofen for pain occasionally when she needs it. Her psychosocial history. She's married, her husband is supportive and helpful with everything. She has 3 kids, 1 preteen and 2 teenage kids who sometimes cause her stress. Works in administrative office as administrative assistant, and it's busy work for her. Denies smoking or use of any illicit or recreational drugs. Consumes 1 to 3 beers per week. Family history. Her mother and her sister both has migraines. Her uncle has a history of brain tumor that was benign and was successfully treated. Let's go over her system, review of system. Denies any trauma to head, denies any fever, chills, numbness, or weakness. Reports sensitivity to light with the headaches and spots in her eyes right before the headache begins. Denies any sinus problems or neck stiffness. Reports sensitivity to noise with the headache. No nosebleeds with the headaches. Denies any upper respiratory problems. Occasional nausea with headaches, but rarely vomits. Denies any weakness. Let's go over objective data. She's afebrile, her pulse is 86, her respiratory rate is 12, and her blood pressure 140/90. Now let's go over her physical exam. Well groomed with appropriate manner and speech in no apparent distress. Her sclera is clear, her conjunctiva without injection, perla, her extraocular eye movements are intact, negative for AV nicking or papillary edema. Optic disc is with clear margins. Her ENT, negative for sinus tenderness on palpation, nasal mucosa without erythema or drainage. Her cardiovascular and her respiratory assessments, both unremarkable. Her neurologic assessment, sensation and proprioception are grossly intact. She has negative Romberg's test, negative Brudinsky and Kerring sign. Her gait is steady, and cranial nerves 2 through 12 are grossly intact. So based on our assessment and history, most likely we are going to diagnose Joanne with migraines with aura. So our differential diagnosis is going to be migraines without aura, cluster headaches, tension headaches, meningitis, temporal arthritis, and psychogenic headaches. So our plan for treatment will be, we're going to do some labs, we're going to do CBC with DIF, We're going to CAT scan and we're going to start some medicine. But let's go over her differential diagnosis. Since she has flush and spots in her eyes, we're gonna exclude migraines without aura a differential diagnosis because flush spots in front of her eyes, well, we're gonna consider it as aura. So her migraines gonna be with aura because those spots in front of her eyes happen right before the headaches or migraine begins. A cluster and tension headaches have a little bit different symptoms and a little bit different pain and location of pain, different presentation than current presentation of our patient. Meningitis is a possibility, but her Burdinsky and Kering sign was negative. She doesn't have any neck stiffness. She doesn't have any um, fever, but we're still gonna do CBC to check her white blood cell count to make sure she doesn't have infection, because if she does have meningitis and we miss it, it could be deadly, especially if it's bacterial meningitis, which can kill you in a couple of days if not treated appropriately on time. Temporal arthritis, not likely in this case since she is a little bit young for it, and temporal arthritis usually comes with other disease, I forgot the name, but it's not going to be, most likely not in our case. If she would have temporal arthritis, we're going to refer her to ophthalmology right away. So we're going to do CAT scan of the head to rule out any underlying pathology. We want to check her for any brain tumors since her uncle has history of benign brain tumor. So we're gonna rule out all of that with the CAT scan of the head. Psychogenic headaches, it's a possibility. She has some stress with her kids and at work, which occasionally starts her headaches, but in our presentation, it's probably most likely it's going to be migraines with aura for her. So our treatment plan, if everything comes back negative, her blood work is good, if her CAT scan is good, we're going to start her on topiramate or Topamax 25 milligram QHS. Before we start this medicine, we're going to do also BNP to check her kidney function since this medication is renally cleared. Our goal for Topamax is to be 50 milligram PO BAD, but we're gonna slowly increase the dose every week. So we're gonna start her on 25 milligram QHS, and we're gonna ask her to come back in a week, and we're gonna reevaluate her headache or migraine and slowly titrate medicine up to the goal. The other treatments for the migraines, it could be non-steroidal. It could be suppressive therapy, which is going to be like non-steroidal anti-inflammatory, acetaminophen, SSRIs, propranolol, amitriptyline, and some other medication. And for abortive therapy, there's some triptans, ergotamines, and the other drugs. But in her case, since she has migraines only for 2 weeks, 3 to 5 times per week, we're going to start her on suppressive therapy with topiramate 25 milligram HS. She had a high blood pressure on admission, not on admission, in our in office. It most likely because she had 7 out of 10 pain. The blood pressure elevation probably was related to the pain. Next week when she comes to the office, we're gonna recheck her blood pressure, and we're gonna also ask her to check blood pressure at home during the time when she doesn't have headache to assess her actual baseline blood pressure without pain. Stress could impact her headache, so we're gonna educate her on stress management techniques and like yoga, going to the gym, going for runs for the stress relief. If her CAT scan would show anything unusual, or if she develops any neurological symptoms, we might need to refer her to neurology or to neurosurgeon if she's gonna have anything on CAT scan like brain tumor or something different. If she was a smoker, we would encourage her to stop smoking, as smoking can cause or can start the migraine headache. If she was on any birth control pills, we're gonna also stop them because birth control pills can also start the migraines, headaches. But she was only on ibuprofen PRN, so she haven't been on any pills and she doesn't smoke. So yeah, we'll see our patient in a week and we'll go from there after we see our test results back. Thank you.